Good evening, everyone. So everyone can see my slides?
Yes.
Yes, yes.
Okay. So good evening, everyone. I am Dr. Quazi Shahid-ul, working as an assistant professor in Pediatric Orthopedic Department, Dhaka Medical College Hospital. And today my topic is surgical treatment of septic hip sequelae. So let me give you a guideline how we are going through this topic today. First, we are going to know what are the sequelae of septic hip. We are going to know about some classification systems. Then the treatment options name only. Then the steps of procedure for different options as much as possible. Then what to do for different deformities that develop as a sequelae of septic hip. And last of all, few cases illustration. So what is septic arthritis? It's a pathological microbial invasion of joint space associated with inflammation. It is also known by many names, but among them, pyogenic arthritis, infective arthritis, and suppurative arthritis are most common. These are the most common sequelae of septic hip. Coxa magna, that is the enlarged head. Coxa breva, that means the shortening of neck. Coxa vara, coxa valga, leg length discrepancy, pseudoarthrosis of the neck of the femur, pathological dislocation that leads to joint instability, and stiff hip that results due to bony ankylosis. A lot of classification systems are there for the sequelae of septic arthritis. Among them, the Honka, Choi, Forlin and Milani, Johari, and Eyre-Brook classifications are most common. But the Choi classification are most widely used. So we are going to look into that classification only right now. In Choi classification, it has got 4 types, 1, 2, 3, and 4. Each of them are again subdivided into A and B. In Choi type A, there is no damage to the head or physis or neck. They are the most luckiest one. Almost all of them can develop a normal hip later on. But some develop coxa magna due to increased vascularity. If they develop like a normal hip, they will be classified as type 1A. If the coxa magna develops due to increased vascularity, they will be classified as 1B. In Choi type 2, this occurs due to fascial affection. The physis is either damaged partially or completely. If the total physis is damaged, it will be classified as 2A, that will lead to coxa breva, that is shortening of neck. But if the portion of the physis is damaged, then it will be classified as 2B. If the medial portion is damaged, it will lead to coxa vara. If the lateral portion is damaged, it will lead to coxa valga. If the anterior or posterior part of the physis are involved, then it will lead to anteversion or retroversion respectively. In Choi type 3, here the total neck actually got destroyed. And after the destruction, the head actually slipped from the destroyed neck. If the slip occurs with a varus or valgus angulation or version changes or either in a combination of these, they will be classified as 3A. But if it leads to a pseudo neck arthrosis, a clear gap will be seen in between the head and the rest of the femur, and they will move as a separate pieces. When you try to see them in dynamic X-rays, it will be classified as type 3B. And lastly, the type 4, the most destructive one. It will again divided into A and B. If the total head and neck are destruction are here, and if the total head and neck are destroyed, but a medial beak is present, a little bit one beak is present, which will help or give us some sort of stability, it will denote it as type 4A. But if the total thing is destroyed and the proximal femur got rounded up, then it will be classified as type 4B. So this is about the Choi classification. It clearly denotes where the lesion is. So I will introduce the poll question here. Once I start the question, you will have 10 seconds to answer them. Among the question, you can click only one of them. So let us begin our first poll question. Your time starts now. So when to start the treatment? When the septic hip sequelae is diagnosed. You can start immediately after diagnosis, or you will wait till the skeletal maturity. You will wait till the infection subsided, or you will operate even for the minor deformities. So after 30 seconds, I can see that almost 69% of the participants tell us that we should start the treatment immediately after the diagnosis. So let us see what we need to do for the septic hip sequelae once the diagnosis is made. Whenever you diagnose it as a septic arthritis sequelae, you should not start the treatment immediately. It needs to be delayed because it needs some parameters to calm down first, and it has to be confirmed both clinically and biochemically, because there is always danger of reactivation of old infection. So we have to make sure there is no active infection or latent infection right now. The strength and the general state of the bone need to be improved with time also before you do any operative procedures upon this diseased bone. Status of the proximal femur and femoral head should definitely be determined before any procedure has to be taken. And this can be done by either by arthrogram or by MRI. And there is always high chance of remodeling. So if there is a minor deformity, you should give it some time to get it corrected by itself because of the growing property of the child bone. You should not do anything for them. So the septic arthritic sequelae treatment, you should delay before making these decisions. Make sure that there is no infection and make sure that the deformed bones are strong enough to hold any operative procedures. So what is the goal of the surgical management for our septic hip? We need to stabilize the joint. We need to correct the deformities if present. We need to equalize the length. We need to retain the mobility and relieve pain if it is present, and also minimize the risk of developing pain later on. So let us see our options, what we can do to achieve these goals. If you want to stabilize the hip, we can go for trochanteric arthroplasty. We can go for pelvic osteotomies. We can go for realignment osteotomy like varus, valgus, or derotation osteotomy of the proximal femur. We can go for pelvic support osteotomies. Or we can go for hormone reconstruction also. I will elaborate each of them a little bit later on. If you want to correct the deformities only, then this realignment or derotation osteotomies are good enough. If you want to equalize the length, the soft tissue release, epiphysiodesis of the other limb, if the anticipated discrepancy is about 2.5 to 5 centimeter by the skeletal maturity age, or you can go for the lengthening of the same limb if the discrepancy is more than 5 to 6 centimeter. Definitely Elizarov will help us a lot at that time. If you want to just relieve the pain, we can choose it when the normal relationship between the femoral head and the acetabulum cannot be restored by any of the means I mentioned so far. And the movement of the hip, of this deformed hip, is actually producing pain. So what are our options? We can either go for arthrodesis. We can excise the deformed femoral head remnant, that is almost like a girdle stone arthroplasty, or we can go for modular hemiarthroplasty or even total hip arthroplasty depending upon the clinical scenario. So let us now see few of these options as per textbook. If you want to go for varus and valgus ostomy, actually this procedure are required in many of our pediatric orthopedic procedures. So let me show you a graphical representation how and what actually we do in case of varus or valgus osteotomies. So look at this X-ray on the right side. You can clearly see it is a coxa vara. The neck shaped angle is reduced. So we wanted to do a valgus osteotomy for the right side. So first we need to determine where we need to go for the osteotomy, and it is usually recommended to go for the osteotomy at the subtrochanteric region. So assume that we will do this osteotomy like this, and this will be our two anticipated fragment after the osteotomy. We will take a DCP and we will bend like a C shape to accommodate the curvature of the greater trochanter, just like this. Once we achieve this C-shaped arrangement, then from the osteotomy side, the distal portion of the plate will be taken, angulated away from the midline. That is why we called it valgus osteotomy. Then we will complete our osteotomy at the fractured bone, align that fractured bone with that angulated DCP's distal part, hold it with the bone holding forceps, let all the screws in. And now when I put the leg into its normal back, into its anatomical position, you can clearly see the valgus osteotomy has done its job. The varus osteotomy is no more and the neck shaft angle has been restored. If you want to do the varus osteotomy, you will just do almost the same thing, but instead of angulated away the DCP from its distal side, away from the midline, you will put it towards the midline. So have a look at it also. So these are my proposed osteotomy site and proposed fragments. DCP to maintain the curvature of the greater trochanter. Then we angulated it medially and align our osteotomy bone towards it. Let all the screws in. And then when I put it into normal anatomical position, the angle will be into a varus position. Remember, this procedure we can also use in LCPD also, where we put the lateral column more into the anatomical weight-bearing line. So look at this position of the outer margin of the lateral column of the head. When I make the varus osteotomy and align the leg into its normal anatomical position, you can clearly see it will move into the acetabulum more into the weight-bearing line, just like this. So that is why this varus osteotomy we can use in the LCPD also. Trochanteric arthroplasty. It is first described by Colonna. Here the trochanter is placed into the acetabulum and the abductors are transferred distally, and these are achieved after making an angulation at the femur. But remember, it is clearly written in most of the journals that it results unsatisfactory in 1/3 of the patient if the age is below 6 years of age. And above 6 years of age, it is virtually unsatisfactory for all patients. So it is definitely not a very good procedure, but sometimes it may be the only option we have. So this is how it was done. We first remove the abductors from the greater trochanter from here, and then we make a varus osteotomy to get this greater trochanter into the acetabulum, and then reattach these abductor muscles to a distal to the fracture site. This picture has been taken from the Rockwood book. They have shown that they have done a Colonna greater trochanter arthroplasty in a 5-year-old boy, and at 11 years old follow-up, they have shown that this greater trochanter is now acting and looking like a head. Another surgical option is hormone reconstruction. It is specifically indicated when the head is totally destroyed, but fortunately the remnants of the neck are still covered by some unossified hyaline cartilage. Here what we do, we did a sagittal split in the upper proximal femur. Then we split it and maintain that split is formed with the help of some bone graft taken from the tibia, and the medial projected part is entered into the acetabulum with the hope that it will act and look like a head with regular follow-up. We can go for some pelvic osteotomies. Most of them are required for the coverage of the head. We can go for Salter osteotomy, Chiari osteotomy, Pemberton osteotomy, or Degas osteotomy. All of them support the proximal femur when the head and neck are totally absorbed. So let us have a look at this pelvic osteotomies now, what actually we do in these osteotomies. First, the Salter osteotomy. Here we make a osteotomy just starting from the just below to the anterior inferior spine and extends up to its medial cortex just above the level of the ischial spine. Here both the cortexes are osteotomized. And then this lower fragment, with the help of a distractor, we pull down. And look, when we pull it down, it covers the head much more better than before. So it actually produces a kind of lateral open wedge osteotomy. So we need to fill up this gap. So a bone graft is required and that is put into that place. As the both cortexes are osteotomized, so this left iliac bone is kind of unstable. So we need a screw or K-wire to hold them in position till it gets united. So this is what we do in Salter osteotomy that increases the coverage of the head of the femur. If you want to do a Degas osteotomy, the osteotomy site is now much below than the Salter, just above the level of the acetabulum. And we do not go up to the medial cortex, maybe up to the middle portion. Once we did that osteotomy, then this lower portion is again driven down with the help of a distractor to increase the coverage. Again, we need a bone graft to fill up the gap. But here, as the medial cortex of that iliac bone is still intact, we do not need any fixator for it. Afterwards, this DEGA procedure, we are going to keep that child in a hip spica for 6 weeks. By that time, it will get united because it's a highly cancellous area. If you look this same DEGA osteotomy in a sagittal plane, this is how actually it looks like. Lateral cortex and medial cortex, we make an osteotomy from the lateral cortex up to this middle through the cancellous bone. We pull down the below compartment outwards to make the coverage increased, get a bone graft into it, and that's how the DEGA procedure is actually done. The similar procedure is applied for the Pemberton also. But the main difference is if you drop down the anterior 2/3 of the acetabulum, it will cover the anterolateral portion of the head of the femur, and then we called it Pemberton. It is actually required for developmental dysplasia of hip. If you put the acetabulum in this posterior 2/3 to increase the coverage at its posterior medial side, then we call it DEGA. So that is actually required for any spastic hip dislocation where the coverage is required, mainly for spastic hip dislocation in case of C. Chiari is a salvage operation. When none of the pelvic osteotomies are possible, then we do this Chiari operation to give some sort of coverage to the uncovered femoral head. Here we do a transverse osteotomy, and then the inferior segment of that pelvic girdle is pushed medially and fixed it with some K-wire or some screws. Here, the head of the femur is now in direct contact with the bone of the ilium above. The fibrous capsule that lies in between these two bone fragments will be modified and converted into a fibrocartilage that will help as a hip joint. Another very important surgical option is pelvic support osteotomy, which is required for Choi type class 4 and some part of class 3 also. It is actually a proximal femoral osteotomy, also known as chance osteotomy. Here, we make an angulation at the ischial tuberosity level after maximum adduction. So suppose this is a diseased septic hip and we want to do the chance osteotomy. First, we adduct the whole limb maximally as much as possible, just like this, so that the remnant of the neck or the lesser trochanter, whichever is available, will come in close contact with the acetabulum. Once we achieve that contact, then we need to realign the distal part of the femur, that is the knee joint, back to its normal mechanical axis point. So we make the osteotomy and put it back into its normal mechanical axis. So the center of the hair, center of the acetabulum and the center of the knee joint falls aligned into the normal mechanical axis. But many of the times, this adduction only angulation doesn't make sufficient contact of the remnant of the neck of the femur with the acetabulum. So it cannot support it. So in some cases, we need more angulation. For that reason, after the first osteotomy, we actually abduct the femoral component, the distal femoral component more, like in this position. This will make more contact of the proximal femoral osteotomy site with the acetabulum. But the femur is now in a more abducted position, more away from the mechanical axis or weight-bearing line. So a second osteotomy is actually required into the femur to put the femur back into its normal mechanical axis line. So it's a double level chance osteotomy, but both of them are pelvic support osteotomy. And all of this pelvic support osteotomy can be done by irresolute procedure also. I will show you an example later on. If you want to just want to relieve the pain because no other options are available, then we can go for arthrodesis. And this is the functional position where we need to make the arthrodesis happen. 30-degree flexion, 0 to 5-degree abduction, and 15-degree external rotation. We can go for modular replacement hemiarthroplasty or even total hip arthroplasty when indicated. But remember, because it's a sequelae of septic hip, by the time we took this decision for this hemiarthroplasty or total hip arthroplasty, the proximal femur has been migrated way above the acetabulum. So we need to bring it down before going for these procedures. So this iliofemoral distraction will help us a lot. With this distractor, with the help of this distractor, we just put down the proximal femur back to its normal anatomical alignment, and then we can go for this hemiarthroplasty or total hip replacement. And as I've told you, this pelvic support osteotomy can be done by laser of reconstruction also. And if it is done, it will look like this. Our professor, Dr. Mofakkar Bari, has published these procedures in a recent journal also. But I will advocate for all Elizabeth surgeons to do this only if you are experienced enough. Any Elizabeth surgeon who do like 4 or 5 Elizabeth per year should not attempt this. That is my personal opinion. So let us now see what can we do when we classify this devastating condition. So we know how the classification is, and we know all the options on the name of the options and how to do them. So let's now see what to do when the condition is. So if it is a TOEI type 1A, that means the femur has regained his normal size and shape. So we can only go for, wait and observe, and maybe a secondary osteoarthritic change develop later on. If it develops as type 2 1B, that means a coxa magna is produced, then the treatment is actually individualized. If the patient is symptomatic because of the uncovered large femoral head, we can go for pelvic osteotomies to cover the unexposed part of the coxa magna, but it requires very rarely. If it is a TOEI type 2A, that means it is a coxa breva. There is a shortening of neck. So the abductor levering mechanism is actually hampered. If it is still in the childhood space, we can do the trochanteric epiphysiodesis for this patient so that this deformity remains stable. It does not progress into varus or valgus position. But if it is presented at skeletal maturity, we can make the trochanter advancement as a relative neck lengthening so the abductor mechanism regains its normal activity. Plus minus pelvic osteotomy can be also advocated in type 2A. If it is a type 2B, that means a coxa vara or valga produced because of the fascial affection, then we can go for our realignment osteotomy, that is the varus or valgus osteotomy, whichever is required. But always remember to go for the growth arrest of the trochanter to prevent the recurrence. Otherwise, whatever the varus or valgus osteotomy you achieved, if the trochanteric physis is still alive, because it is growing alone, the neck physis is already damaged, then it will again lead to deformity. So don't forget about the fusion of the greater trochanter whenever you go for realignment femoral osteotomy for septic arthritis sequelae diseases. And you can also consider epiphysiodesis of the contralateral limb or the lengthening of the ipsilateral limb to deal the LLG even after at the same sitting or at the later period. If it is a type 3A, that means the neck is totally destroyed, only the head is viable, but it has slipped into a varus or valgus position. So we call it 3A. Again, the same realignment procedures, just like 2B, will be advocated. But if the pseudoarthrosis is there, which will be evident by dynamic X-ray, that will show that the head and neck are actually moving separately, then you definitely need to go for valgus osteotomy with compression screw with plus minus bone graft. If it is a type 4A, that means the head and neck are totally destroyed, but a small medial beak is present, then that hormone reconstruction you can proceed. But the age has to be less than 6 years of age. Don't forget to transfer the greater trochanter along with the abductors if you go for hormone reconstruction procedures. But if the child is more than 6 years of age, even it is a type 4A, then treat it like type 4B. So let me now focus what we can do for type 4B. That is the most devastating one. The total head neck is destroyed and the proximal femur is now rounded up. If the child is less than 6 years of age, you can go for trochanteric arthroplasty as I've shown you before. But most of the journal is shown that it do not have any bright result. In that case, you can directly go for pelvic support osteotomy. Or if the child is more than 6 years of age, definitely you need to go for pelvic support osteotomy, which can be done by Elizabeth reconstruction osteotomy also. So now let us have some case illustrations. An 8-year-old child diagnosed as a case of septic arthritis when he was 4 years of age. But the parents didn't take any treatment, though they were advised for admission, open debridement, and IV antibiotic. Now they ended up with limping gait and pain. And this is his current X-ray right now. You can now clearly see it's a TOEI type 3A. Though a gap is seen over the X-ray, but when you do that dynamic X-ray, it shows that they move as a single unit. So we classified is at TOEI type 3A. So what can we do for him? So let us again have a poll question for our audience. So what can you do for this child? So this is the X-ray. What can we do for him now? We can either go for varus osteotomy, we can either go for pelvic support osteotomy, we can go for valgus osteotomy, or we can go some pelvic support osteotomies also only. So please pick either one of them in your results. So I can see that most of the participants has voted for PSO. So let's see what we have done. We actually did a valgus osteotomy. Look at the X-ray. It is clearly in varus position. So that is actually his main problem. The more pressure he puts, it is going into varus position. The greater trochanter is going upwards, decreasing his abductor function mechanism, and that is the reason he is having pain and the limping, along with the limb length discrepancy. So you definitely need to go for valgus osteotomy. And this is what we done. And we also go for trochanteric fascial growth. Remember the position of this screw. This is the one which will actually arrest the growth of the greater trochanter. During paraoperative period, we feel that there might be a pseudoarthrosis also. So we didn't take any chance. So that's why we put these two compression screws along with it. The limb length discrepancy is now 1.5 centimeter. The child is 10 years of age. We gave them the option to go for contralateral epiphysiodesis because the anticipated growth will exceed 5 centimeter by then. But the parents didn't agree. They wanted to wait and see. So we agreed with them. We didn't do anything for the limb length discrepancy, which is about 1.5 centimeter right now. Second case. A 10-year-old boy came with a complaint of limping gait and shortening. He was diagnosed as a case of septic arthritis 4 years back. That means he was 6 years of age at that time and was treated by open debridement of the joint, but no radiology were available at that time. After 2 years, when he was 6 years of age, they did a check X-ray. This was the X-ray at when he was 6 years of age. It is clearly showing that the coxa vara has developed, and it is also showing that early signs of AVN is already set in. But they didn't took any treatment right now. It is TOE type 2B or 3A at this moment. After a year, when he was 7 years of age, now he visited a local orthopedic specialist. That is 3 years after the initial diagnosis. And this was the X-ray at that time. As you can see, the coxa vara is now more evident with the appearance of a pseudoarthrosis. According to the discharge summary, the orthopedic surgeon did the valgus osteotomy, but he did not mention anything in the discharge summary about the trochanteric fascial growth arrest done or not. So we could not anticipate it. We could not guess what was actually done for that patient. But after 1 year, when he came to us, this is the check X-ray when he presented to us. We can clearly see that the varus position is still there. So someone can guess that the primary surgeon may not achieve the valgus as much as required when he tried to go for the operation. But look at the other few factors. The greater trochanter actually is larger right now. So that means it is still growing up. So definitely either the trochanteric epiphysiodesis were not done or not done properly. But because of the position of the screw, I believe that he actually tried for trochanteric epiphysiodesis. But for some reason, it didn't work. And look at the neck of the femur right now. That pseudoarthrosis is no longer that much visible because it is getting almost a close proximity. So I will also assume by that valgus osteotomy were definitely achieved initially, that put his body weight in a transverse position that helps his uniting of the pseudoarthrosis. But because of the failure of this trochanteric epiphysiodesis, this one actually going into varus again. Whatever valgus the primary surgeon achieved, it is again going into varus position because the trochanteric epiphysiodesis was not done completely. So again, now we have a third hour poll question. So what can we do for this child right now? So he had already done a varus osteotomy with failure, and the trochanteric epiphysiodesis may not be done properly. So he is now 8 years of age right now, presented to us with a limping gait. So what can we do for him? We can either go for pelvic support osteotomy. We can just simply remove all hardware and wait for the skeletal maturity. We can go for valgus osteotomy alone, or we can go for valgus osteotomy with trochanteric transfer. So this is our result. I can see that only 1 people went for pelvic support osteotomy. 9 people advocate for removal of all hardware and wait for the skeletal maturity. 2 people advised for valgus osteotomy to be done again alone. And 13 people advised for valgus osteotomy with trochanteric transfer. So let us see what actually we did for the child. We again did the valgus osteotomy. And this time we do not know exact the condition of the fascial trochanteric physis. So we did the trochanteric fascial growth arrest, but we do not take any chance. We transfer the trochanter into a more distal position so the abductor mechanisms can now work well. His gait improved postoperatively because of this trochanteric transfer also. Limb length discrepancy is again now 2 centimeters. The patient parent didn't give us any consent to correct the deformity in the same sitting. Third case, a 14-year-old girl came with a complaint of limping gait and with pain. In the past history, we found that the child was not bearing weight on his left side since the walking age. He had fever and swelling at his hip that was treated by a general physician and subsided gradually when he was 6 months of age. This is the X-ray that were taken when he was 2 years of age, but they still didn't take any advice that were given by the local doctors. From the X-ray, you can clearly see the head is not visible on the left side, and the femur is pushed far laterally from if you compare with the right side. So my question is, do you think the head and neck is totally destroyed over here? Or do you think they are totally absent or present over there? So let us have our fourth question. You just gave me an answer that whether head is present or not in this scenario on the left side. So almost 64% of our participants agreed that the head is definitely over there. The rest thinks that head is not there, it is totally destroyed. So let me share some information when you see this kind of X-ray, how you can assume that whether head is present or not. First of all, look at the Shenton's line. Even if the femoral component is pushed in lateral position, you can see that the Shenton's line is still actually maintained. That actually indicates some sort of head is definitely over there. Look at the pelvic acetabular index of the pelvis. The left side is still not that much straight up. It is still curved. That means some sort of head is definitely there, which is causing friction, and that is helping the acetabulum to grow in its normal, usual fashion. And the third important one, look at the triradiate cartilages. Both the triradiate cartilages are still in same equal size. That also indicates that the head is present. If the head were absent, then this acetabular index will not maintain its angle. And this triradiate cartilage will try to close down if you compare with the opposite side. So these three information will help you to identify whether head is present or not, even it is not available in the visible in the X-ray. But it will not give you an idea whether it's a deformed one or deformed one or intact one. We definitely need to go for arthrogram or MRI for that. So that child actually presented with us when he was 14 years of age. And this is how the X-ray looks now. There is a very minimum pain, but he walks with limping and shortening. It's a typical 2A type class 3A. A varus position is noted. But look at the greater trochanter. It is shooting up like a rocket. It is going upwards and reducing the abductor mechanism for that child. That is producing a deformed cage. So as he is a 14 years of age, so we did the same valgus osteotomy, but this time we did it with a DHS. We also did the trochanteric transfer to make the abduction mechanism working better. Few points I need to point out in this X-ray for all of the audience. Look at the alignment of the proximal and the distal fragment. I didn't even try to make them as a single line. I put the proximal fragment directly into the medullary cavity. Believe me, if you make careful dissection, if you can maintain the periosteum intact, even up to the, even this kind of position will heal up perfectly, because this position at this it was required to maintain the correct valgus position that were desired by us. And the above portion, rounded portion, is the greater trochanter, which we actually bring down as low as possible and attach it with the proximal femur, avoiding the DHS plate with the help of a screw later. This will be our last case. A 14-year-old boy presented with a limping gait, and the diagnosed as a case of septic arthritis left hip, when that was treated conservatively when he was only 8 years of age. And this is how his X-ray looks now when he is 14 years of age. It is the Choi type 4B. The proximal fragment is totally rounded up. A small beak is actually present over there, but as the child is 14 years of age, we will treat it as 4B, no longer of any treatment option to be given for 4A. So what can we do for this child right now? Our last poll question. So we can either go for total hip replacement for this patient. We can just simply leave it alone for the time being. We can go for pelvic support osteotomies. We can only go for some pelvic osteotomy like Schalter or Dega or Pemberton, or we can go for hormone reconstruction. So we actually got a very mixed pattern of opinion for these scenarios. 3 participants wanted to go for total hip replacement. 23% wanted to leave it alone right now. 23% wanted to go for pelvic support osteotomy. 15% wanted to do only pelvic osteotomies, and 27% wanted to go for hormone reconstruction. So let me explain one thing for sure, why we do not go for hormone reconstruction, even it has got a medial beak. Because as I've clearly shown you in the treatment guideline, that the hormone reconstruction is again very much effective if the child is less than 6 years of age. In this scenario, the child is 14 years of age. So we will treat it like Choi type 4B, for which the pelvic support osteotomy is the recommended one. So we did the pelvic support osteotomy. And after 10 months, this is the postoperative X-ray. The child do not have any pain, but his limping and gait pattern has not improved much. She still walks with little pain whenever he put a little bit more pressure. If I want to criticize some point about this operation, I can clearly point out 2 points. Number one, there is a remnant of the neck which we didn't shave it away clearly, or it has gone again back into a beak leg position. That is actually preventing this whole construct coming in close contact with the acetabulum. That may be a cause. And again, you can clearly see, even if I put this, even if I shave it away, this angulation is not sufficient enough to make a contact with the acetabulum to get a proper weight bearing position. We actually needed more abduction of this distal fragment when we did that osteotomy. So definitely the double level Schanz osteotomy that I proposed, that I shown you before, I would recommend that if you have done this double level osteotomy for this patient, the result would have been much better. But definitely, no doubt, the elixir of reconstruction for this patient is also a very good option. So what are my take-home message? Prevention of complication and sequelae should be our priority. For already developed sequelae, appropriate and timely intervention is the key. Long-term follow-up till skeletal maturity is very much important. And aiming a painless, stable, and mobile joint is the goal of treatment. Thank you all.
Thank you, Dr. Shahid-ul Alam Bobby, for your very nice, elaborative, and very informative speak. Now, I would like to put some questions to you all. That is first question from Dr. Jahid. All the outset. Oh,
this is not a question, sir.
Not a question. Question from Kaisar Rabbi. Sir, is there any septic demarcation regarding the site of osteotomy?
Well, if whatever the books and journals and I have gone through, most of them advocate to do the osteotomy at the subtrochanteric level. So I would recommend for all the young surgeons to do the osteotomy at the subtrochanteric level. But if you definitely wanted to go ask me that if there is a specific demarcation, I actually do not have any answer. Professor Quazi sir, if you want to add on anything.
Professor Quazi sir, can you mention or add something?
I think question was what the site? Site is subtrochanteric. We cannot do the osteotomy above at the trochanter level, no? Because you have to fix the proximal part also with any implant. So, or trochanteric, subtrochanteric osteotomy, either varus or valgus. Femoral proximal femoral osteotomy, always we have to go for the subtrochanteric level.
Yes, sir. Most of the books and journals clearly mention that also.
Another question is, what is the minimum age for total hip replacement in Bangladesh?
I actually do not have any idea what is the minimum age. Quazi sir, if you can add on anything on it.
I think you can unmute Rizvi. Rizvi, I see is here, so he can help us in this answer.
Rizvi sir, unmute sir.
Unmute yourself.
Sir, unmute please sir. Sir, please sir.
Okay, thank you. I would like to thank Shahid-ul for his excellent presentation.
Thank you, sir.
I do not know whether Shahid-ul is working in Dhaka or in
Dhaka Medical College. Dhaka Medical College.
Dhaka Medical College.
Yeah, you're in Dhaka Medical College. Okay,
Yes,
what
sir.
is your position now?
Assistant professor.
Assistant professor.
Okay, assistant professor. Okay, and you are working as assistant professor in the pediatric surgery or in general orthopedics?
No, sir. In pediatric orthopedic surgery department under the guidance of Professor Shahid-ul in pediatric in orthopedic surgery department.
It's okay. I would really thank you again for your very impressive presentation. And this is a area where we have our very limited experience. Actually, in our country, so far we have been treating this septic arthritis, and we have been teaching that you can prevent damage as much as possible by doing surgery as early as possible. Okay, and we have a lot of neglected cases with this kind of deformities. We hardly handle this case very scientifically. Now I am very happy to see that you are doing a lot of cases and difficult cases. Anyway, with this satisfaction, seeing that you presented so nicely, I would like to answer the question. Question was, what is the earliest age for total hip replacement?
In Bangladesh. In Bangladesh.
The best time for total hip replacement is after the bony maturity. So it is better if you can wait for 18 to 19 years and then you can do total hip replacement. But I myself has done total hip replacement in a 17-year young boy. Okay, so can be done early, but it is better to do it after the skeletal maturity. Better wait some time and give the chance to bone to get matured. Okay, thank you.
Rizvi, I want to discuss with you just one point. That point was raised in the last lecture also. After this osteotomy of the varus or valgus, osteotomy at 6-7 years of age, and then after the maturity, can we go for the total hip? Is there any problem of total hip replacement?
Yeah, is a problem.
The osteotomy.
As for example, in one case, we have done son's pelvic osteotomy, pelvic support osteotomy.
Oh, okay. That is the I am not talking about sons. The varus or valgus osteotomy.
Okay, it's all the same. Whether you do varus osteotomy or valgus osteotomy, if you make deformity in the proximal femur, then you may have problem in inserting the stem. If that is the case, if you see the stem is so much deformed that you won't be able to put the stem inside, then you will have to do osteotomy again to correct the deformity and can then do the totally replacement.
Can it
Possible.
be, can it be done on the same sitting?
Same,
Or
but the same sitting. You can do that osteotomy. As for example, when you do a DDH and we do osteotomy in the proximal femur, okay, and in the same when the patient with deformity in the proximal femur, somebody is doing totally replacement, so he must correct the deformity and then do the totally replacement.
Thank you, thank you.
Thank you, sir.
Rizvi, the comment, thank you for your nice comments about the pediatrics orthopedics. So these things are coming because we could start the pediatrics orthopedics, you know. So the people are taking interest.
This is the beauty of specialization. If somebody is actually interested in a particular topic, particular subject, and he goes on improving himself, then other people start learning from him.
Yes.
Okay. We have learned our surgeries from our senior people, and we have improved to a extent on that. So our younger generation will have to do this specialization. They have to go on improving themselves, and from them, other people will learn. The operation Shahid has shown us, operations are not difficult, but decision making is most
Decision
important.
making and indications and all these things.
And he'll have to learn from somebody how to do this, how to handle this procedure. Okay, so this is important. It's a good thing. Thank you. Ramda also can take some credit of improvement of this pediatric surgery in Bangladesh.
Now
So
this is not my
everybody should get some appreciation from my part.
thank you for the appreciation, Rizvi. Next question,
Next
maybe.
question is why no bone graft is Pemberton osteotomy from Ashikur Rahman.
Ashikur Rahman, he is one of my resident students. Actually, Ashikur Rahman, definitely we put the bone graft just like in Dega operation. I just didn't show it to you to see so that you can people see how the fragment actually comes down in your anterolateral position. But whether you go for Pemberton or whether you go for Dega, whenever you make that open ways osteotomy on the anterior two-third or posterior two-third, definitely an appropriate size bone graft has to fill up that gap. Otherwise, you will not be able to maintain that downward position of the acetabulum. So definitely you need a bone graft in that Pemberton osteotomy also. I just show you a graphical presentation before the bone graft for better understanding. That's all.
Shahid, you have not mentioned triple osteotomy in the pelvis, in the acetabulum. Triple osteotomy.
Yes, sir. I didn't mention because I do not have that much time to mention all of them.
So okay. When I was visiting Birmingham, okay, about 7-8 years ago, not 7, 5, 6 years ago, I visited Birmingham, and there I found a surgeon. They are very frequently doing triple osteotomy in the adolescent and young adults.
Yes,
with
this
kind of
also
problem.
known as ganj osteotomy, and they
Yes,
advocate to do that when the triradiate cartilage is almost fused or nearly fused. Only at that time the ganj osteotomy is actually advocated.
Good.
Next question.
Next question. If pathological fusion occurs without deformity, what is the treatment options?
I think he wanted to mention about the pseudoarthrosis because that is the only option where this pathological fusion can occur. If the deformity is within acceptable range, then you need to see how the coverage of the deformity is. If the coverage is less, you can go for the pelvic osteotomy to increase the coverages. If you see that the greater trochanter is not in normal position, even though there is no deformity, you can realign the greater trochanter to increase to make sure the abductor muscles can work well. That is also known as trochanteric transfer. So these are the few options that you can advise if the fusion occurs without any deformity, even after that.
Shahid-ul, the question was if there is fusion of the hip joint without any deformity.
Oh, fusion of the hip joint, sir.
If there is fusion of the hip joint without any deformity, how will address this patient?
Okay, sir. If it's already fused in an acceptable position, so that
then I would rather keep it but only problem would be it cannot be without any deformity, because there would be
Yes,
shortening
sir.
of the limb. Okay,
Right, sir.
so the shortening would be there. It would be shortening, so we'll have to address that.
The
But
sort
if it is fused and if it is young adolescent, I would rather prefer not to
do
touch
anything.
it than do anything.
Yes. Yes, sir.
Next question.
Next question is from most probably Faruqi. Indication for trochanteric transfer. Indication for trochanteric transfer.
Okay, thank you for the question. But remember, you have specifically mentioned the trochanteric transfer, not the trochanteric fascial arrest. So when you wanted to do the trochanteric transfer, it is actually indicated for two reasons. Number one, I have already mentioned that if the abductor muscles are laxed because of the upward position of the greater trochanter, then you need to transfer it back to a little bit below position so the abductor mechanism can work well. That is one indication. And another indication is in case of any coxa vara, in case of a near maturity or adult, when we do not want to go for any valgus osteotomy, we can cut the greater trochanter, put it into the subtrochanteric level at the lateral side of the femur, and that will actually increase the length of the femur. And this is what we call relative lengthening of the neck of the femur, which we can do for any near adult or any near adult patients. So these are the two indications where we can go for trochanteric transfer. I would ask Sarwar Ibn Salam sir to add few comments on this if you know anything better than me, sir.
Actually, about the
Indication of
trochanteric transfer, when we do, isn't that?
Yes, sir.
You have said it nicely. Actually, when there is varus of hip, this abduction process gets weaker, and for that reason we do it. In many instances, you have shown there, and for that reason only it is done. Anything else, sir, Professor Quazi, sir?
No, I think it is already answered that.
Well answered.
After the fusion of this trochanteric epiphysis, you have to go for the trochanter transfer. And before fusion, if you fuse this trochanteric epiphysis, there is chance of correction of the deformities in the trochanter. No? Trochanter will not grow much. But after at the end of the fusion, you have to transfer the trochanter down.
And one more thing, Bobby has told already that when there is the trochanter is still the trochanteric apophysis is active. If we just destroy that apophysis, then there will be relative neck lengthening, and there will be some valgus. So that is also one thing that has already been told by Qazi Bobby, Qazi Shahid-ul Bobby.
Professor Mufakkar Bari sir, most probably he raised his hand and he wants to say something. Please unmute, please. Mufakkar Bari sir, he wants to say something.
Regarding this,
Yes, sir.
trochanteric, I'll talk only the trochanteric overgrowth, how to tackle that one. It's very important. You can do drilling and distalize and lateralize the trochanter. When trochanter is overgrowth, how will tackle that one? To distalize and lateralize the trochanteric overgrowth. This is the answer.
Next question.
Yeah, that is the reasons Shahid already mentioned. Actually, to restore the biomechanics of the hip joint. If the trochanter is high up and this abductor is not working very well, and trochanter is abutting in the abduction, abutting against the ilium, then you'll have to correct these deformities to restore the ideal biomechanics of the hip joint. Okay, and you do it by, as you have mentioned, by what do you call it?
Distalize and lateralize.
Yes, distalizing and lateralizing.
Yes, sir. Next question from Abu Jafar Muhammad Salimullah. Why initially double osteotomy not done in last case? That is Bobby. Your last case was, yes.
Yes, sir, I know, sir. Because when we did the operation, I personally actually did not have any idea that there is a role of any double osteotomy in the Schanz osteotomy procedures. while I was making this presentation for the POSB along and also for the Korean Pediatric Orthopedic Society, the same presentation, then I actually read a lot of books, and then I realized that there was a second option that we call this double femoral osteotomy. So if you want to blame me on that, why I didn't know that before the operation, then I accept that apology.
One thing, Bobby, for this pelvic support osteotomy, these are done in 4 ways. Since 1950s, this has been done. So one is Lawrence, one you have said Sanch, and this Elizarov did this this double osteotomy, and further improvement has been done by the great pediatric orthopedic surgeon Dror Palenau. So you have all the options to follow anyone. You have just followed Lawrence. That is the thing.
Yes, sir.
That
Yes,
is the
sir.
thing. He has followed Lawrence. He didn't follow Elizarov here.
Sir, do you add something, sir?
No. So I think Bobby has already told that he was not, he did not know about that double osteotomy at that time. At that time, he doesn't know it.
No problem.
No problem, but we know it, and Barisar has already showed it.
I have a question to Professor Bari. I have a question to Professor Bari.
Bari has pelvic support osteotomy. Bari
is doing.
Bari has shown. Professor Bari has shown us the results. Already.
It's good. It's good. He's a good salvage
double
operation.
No,
I was interested to know from Bari what should be the angle of this fixation after subtrochanteric osteotomy, so that you don't have to do the double osteotomy.
No,
Yes,
I think when there is a need for double osteotomy, you have to do the double osteotomy. Otherwise, you cannot give the pelvic support much. Is it right, Bari, sir? Bari bhai bolen.
আমাকে 2টা মিনিট সময় দেন।
হ্যাঁ।
First of all, আমি একটু elaborately বলে আমি শেষ করে দিব। I will give you the answer of you, Quazi, and my friend Rezur answer দিব। First of all, আমি একটু বলি ববি সম্বন্ধে। তার লেকচারটা যেভাবে সে দিয়েছে, it was just like international standard. আমার খুব ভালো লেগেছে যে সে যে জিনিসগুলো দেখালো, এগুলা নিয়ে হাঙ্কা এন্ড চই সম্বন্ধে সবার জানা উচিত। হুইস চইকে নকল করে এখন ড্রোর পেলে অনেক উপরে উঠে গেছে চইর কারবারটা করে, যেটা বোন গ্রাফটিং করে। আর চইর ক্লাসিফিকেশনটা এখন ফলো করতেছে সারা দুনিয়াতে। এবং হাঙ্কার 5টা, চইর আছে 4B। আচ্ছা, যেনি হাও সে যেভাবে স্টেপ বাই স্টেপ দেখাই গেছে, এগুলা খুব ভালোভাবে সুন্দরভাবে আই অ্যাপ্রিসিয়েট। কিন্তু রিগার্ডিং দি PSO, pelvic support osteotomy, আমি for the juniors বলি 340 cases by Professor Shevtsov done. Kurgan Center link বার করলে PSO তার 40 years এর ফলো আছে 340। এখন রেজভি সাহেব আমাকে প্রশ্ন করেছেন যে কতটুকু করবেন। আপনি যখন PSO করবেন, pelvic support osteotomy, your hip must be mobile হয়ে আপনি you adduct as much as up to the ischium পর্যন্ত আপনি চলে যাবেন। ফার্স্ট যেটা অস্টিওটমি করবেন at the level of the ischium, যেখানে আপনার লাগলো প্রথম অ্যাডাকশন যেটা করবেন, ওইখানে you do the osteotomy. That is called the valgus osteotomy.
Proximal femur has to abut against the pelvis.
Yes, you adduct this one as much as at the level of that you do the osteotomy. এখানে প্রশ্ন আছে যেটা ববি যেটা প্লেট স্ক্রু দিল, প্লেট স্ক্রু অনেকে দেয় কিন্তু জিনিসটা একুরেটলি হয় না, কারণ ইলিজার তুমি গ্রাজুয়ালি আস্তে আস্তে ইউ ক্যান কন্ট্রোল দি ডিফর্মিটি। নেক্সট, যখন অ্যাবডাকশন আমি করে ফেললাম, তখন আমাকে 10 সেন্টিমিটার দূরে, যেটা কুরগান সেন্টার বলে, তুমি ইউ ডু দি অ্যাডাকশন ফ্লেকশন অস্টিওটমি টু মেনটেন দ্য অ্যাক্সিস। যে জিনিসটা কালকে আমেরিকান জার্নালে আমার বের হয়েছে, আমি এটা দিয়েছি, ববি এটা জানে। আপনারা যারা পারেন শুধু বাড়ি ক্লিক করলে হবে PSO, দেখবেন চলে আসবে ওইটা। এখন ওইটা পড়লে তারপর আপনি লেংথেনিংটা পড়লেন, লেভেলটা চলে আসলো। টু মেনটেন দ্য বায়োমেকানিক্স অফ দি হোল লিম্ব, প্রথমে অ্যাবডাকশন, then adduction. Adduction করার পরে you can go for lengthening, whatever you like. And at the same time, your both knee joints should be the same level. This is the principle of doing PSO. এবং ববির আরেকটা কথা বলি, যেটা হারমোন অস্টিওটমি, ভেরি গুড অস্টিওটমি, যদি 6 বছরের নিচে হয় ফ্যান্টাস্টিক, মাঝখানে কেটে দিয়ে এটাকে অ্যাডাকশন করে ওটাকে টকেন্টার করে বানানো যায়। হ্যাঁ, এই সিস্টেম গুলো আছে, কিন্তু পিএসও করতে গেলে আপনাকে অনেক মেটিকুলাসলি সুন্দরভাবে এবং আউটকাম রেজাল্ট ইজ গুড। যাই হোক, আমার ইয়েটা ভালো লেগেছে।
বারি ভাই, হ্যাঁ শুনেন না, রিজভি যেটা প্রশ্ন করছিল যে একটা অস্টিওটমি করে পারা যাবে কিনা, সেটাই আমি বলছিলাম যে না,
তাহলে শর্টেনিং হয়ে যাবে, তো আপনি লেংথেনিং কিভাবে করবেন? পারবেন না। ইউ মাস্ট গো ফর ডাবল অস্টিওটমি।
একটা করলে এত অ্যাডাকশনে থাকবে যে তাকে আবার নিউট্রালে আনতে হবে, আর
বায়োমেকানিক্স আবার অ্যাবডাকশন করার পরে আবার অ্যাডাকশন অস্টিওটমি করে আপনাকে লেংথেনিং করতে হবে, দুইটা, সেটাই হলো প্রিন্সিপাল। জি, থ্যাংক ইউ ভেরি মাচ।
Thank you, sir. Next question from my resident, most probably the ortho resident Khulna, Sheikh Mahfuz Rahman. Sir, what is the ideal age for greater trochanteric epiphysiodesis?
For greater trochanteric epiphysiodesis, ideal is actually whenever you do a varus or valgus osteotomy to correct any deformity, whatever the age of the child is, you definitely need to go for the trochanteric epiphysiodesis, so that whatever correction you achieved, it doesn't go back into its normal, again, deformed position. So definitely there is no ideal age of greater trochanteric epiphysiodesis for that. But if you want to see that the hip is for some reason is going into a varus, but still within acceptable position, and I do not want it to go into a varus position without any surgical procedure. I wanted to fuse the greater trochanter so that it remain in that valgus position. I think in the book it is written that at least 5 to 8 years, between 5 to 8 years, that you can go for this greater trochanteric epiphysiodesis. But I'm not very much sure about it. I would ask Professor R.R. Quazi sir to highlight in on this.
I think your answer is correct. As much as I know that when you are going for any varus or valgus osteotomy, you have to go for the trochanteric epiphysiodesis. Otherwise, trochanter will grow and then your valgus osteotomy will again become varus. That is the answer. And then what is the lowest stage? Lowest stage, I know that even up to 3 years of age, you may have to go for this trochanteric epiphysiodesis.
May have to.
The lowest one. May have to. It is the lowest.
Lowest. Dr. Sarwar Ibn Salam.
Regarding this apophysiodesis of greater trochanter, I agree with Quazi sir. Actually, see for what purpose we are doing this greater trochanteric apophysiodesis. In Perthes disease, when you do the varus osteotomy above the age of 6 or 8, whatever, we do this apophysiodesis. So very well we can see that up to even 6 years we can do it. And we have to remember, if is this apophysiodesis of greater trochanter is going to cause some valgus. So we have to keep in mind at the same time that we do not do too early. In some cases we can do as early as what Professor Quazi sir said. So I would say 5 to 8, what Bobby was telling, that is you can safely do it when there is some virus.
Thank you. Thank you. Next question is from anybody. His name is not mentioned here. In acute conditions of septic hip, should we do arthrotomy and traction or wedge?
Oh, this question is Bobby answered this. Yes. I think he has mentioned is acute septic hip.
Acute conditions, septic hip, should we do arthrotomy and traction or wedge?
Bobby, let me answer. In acute condition, definitely you have to go for arthrotomy and drainage of the pus and debridement. Even if hip is lay, even we see late cases. Say what is written in the book, that within 72 hours you have to go for the arthrotomy. But in our situation, the patient comes late. Even if you go for the arthrotomy, even in late cases, you will not do any harm to the child. Rather, you can have some good results even in late. So arthrotomy will not cause any harm. You are draining the pus, you are relieving the decompressing the joint, so that will help. Don't go for the traction and conservative treatment in case of septic hip.
After drainage for the junior, I request you, sir, somebody put traction after drainage. Can you recommend it?
Traction after drainage. Traction means
What is the
surface
surface traction of this?
Yes, that
He can do
sometimes.
it.
I think that is needed sometimes to give rest to the child, because after drainage, if you leave it alone, there will be a flexion contracture of the hip.
Sir, my question is to you. That is, what approach do you prefer?
In case of septic hip,
Yes, yes, sir.
and previously we are doing even in the posterior approach, but now for the last 10 years, we know more about this septic arthritis or septic hip, that is better to go anteriorly.
Sure.
Posteriorly, the blood supply will damage the blood supply. So posterior approach is not advisable nowadays. Just as that of the elbow, in supracondylar fracture, we are now telling that don't go posteriorly and don't go open reduction. Don't do open reduction by posterior approach in case of supracondylar fracture. You have to go anteriorly. If you are not acquainted enough about the anterior approach, go laterally or medially, but not posteriorly. Like that, in hip, in children, in babies, go anteriorly. Anterior approach is very familiar approach. Or you can go laterally by Watson-Jones approach. But don't go posterior approach, because when you injure the, like that of in adult, when if you injure the external rotators, there's the blood supply comes. So opening posteriorly is no good. This we want to add.
Yeah, as rightly mentioned. Okay, in children, so below the age of 2 years, always go anteriorly using the part of the Spitz-Peterson approach, the conventional approach. But in children, younger children, you can use Watson-Jones approach. Okay, in a young children, in adolescent, in adult, you can use Watson-Jones approach. But in the smaller children below the age of 2 years, always go anteriorly. Okay, this is the part actually. This is the part. If you were handling with a septic arthritis, this is an emergency. Always keep in mind, septic arthritis anywhere, either in the hip joint or in the knee joint or shoulder or elbow, wherever there is a pus in the joint, you will have to release the pus as early as possible, preferably within 8 hours. Within 8 hours. And Dada has mentioned that, okay, if it is late, even then you will have to go. And sometimes I have seen, in my experience, I have seen somebody has already drained the abscess, okay, and then came to me after 10 days having the same kind of problem, and I could detect there is still pus inside, and I went again. And interesting thing is that by doing that second surgery, we could survive the head. There was some destruction of the head. Even then, the head survived gradually. I cannot show you these pictures right now, but I have very beautiful.
Yes. I have also 3-4 cases.
This is very interesting.
I have 3-4 cases. Please be where there is osteomyelitis of the proximal femur.
This is very interesting.
Proximal femur. There is osteomyelitis of the proximal femur. Came late. We drained the osteomyelitis. On that time, we drained the hip and they had survived and remodeled. I have some cases.
Yeah, yeah, it's possible.
At the end of our CMEs, we will have one day with this case reports, case presentation.
Then
we can
then
show
I'll
our
show one or two cases then.
then we can show our cases.
Sir, I want to say one thing is that there is Dr. Sarojini Salam, sir. I have seen Dr. Pune from Dr. Shandip Patwardhan. Yes, Shandip Patwardhan, sir. He shown me a special incision that is anti-inferiorly at the perineal region. That is the incision he gave, and for evacuation of the pus. But I have seen one case.
Medial incision.
Yes, yes.
That was medial approach.
Medial approach. Medial approach
that is not required. Maybe.
Yes.
That is not required. Just follow the approaches you know. We know anterior approach, we know Smith-Peterson approach, and we know posterior approach, but the danger of posterior approach, Professor Quazi has specifically mentioned, avoid that approach. For this, especially for the septic hip.
Septic, right.
There is one point, there is a very rare case that is published in the literature, and I have seen one case that there is a abscess in the obturator internus inside the pelvis, just inside the pelvis, an abscess that we got in after the MRI, and on that case I have drained it through the in between the adductors by putting an artery forceps inside the pelvis through the lesser foramen, and that we can drain. That cannot be drained by any other approach. But this is very rare case, and I think go for the other questions.
And other thing is that nowadays people have started using arthroscopy. Okay.
Yes.
Arthroscopy for the drainage of the pus and the debridement. Okay.
Yeah.
This is relatively safer procedure and not good for the small kids, but for young children that can be an option. Okay. I had a question actually to our Quazi speaker, Quazi Shahid-ul. I find the problem of septic heap in neonates. In neonates, it is very a difficult problem because in neonates having septic hip joint, they do not present with the classical presentation what you see in case of infection. Do you have any advice about this septic hip in neonates?
I do not want to say anything,
do you have
sir.
anything?
I do not want to mention anything right now, sir. I
Tell
can
us
look
about
into it
this
and get back to you later on, sir.
neonatal septic hip.
No, sir.
Okay.
Rumel.
Okay,
Sir,
thank you.
sir, very commonly we find patients, neonatal patients, they used to, those patients who was in NICU.
NICU, yes.
And after going out of NICU, say they were there for 10 days or 5 days, 7 days, 2 to 3 days after that, they used to come to us with fever, with restricted particular hip movement, and those are probably the septic hips. Things happen that the patient was getting so much of antibiotics there, and also was getting those things after the discharge even. So they do not present with all the classical symptoms of septic arthritis, and sometimes they come too late. So many times these patients, we cannot go for this drainage.
Typical arthrotomy, yes.
Typical arthrotomy. There was an interesting debate. It was in Japan. I was there in Japanese Pediatric Orthopedic Society conference, and the great Pakistani pediatric orthopedic surgeon who came here, Javed sir, you know him, sir.
Yeah,
Javed sir was there in the dais, and he was having a kind of debate with the Japanese and the Americans that we can't go for every patient for drainage, every neonate or every infant for drainage whom we suspect that he or she might have septic arthritis, because the patient has come to me after 10 days. Doing
and
that
already these childs are very weak, and
very
you cannot
weak.
give anesthesia
100%.
because already they come from the NICU, no?
So things have to be individualized.
In ICU, these are mostly premature babies or having some immunocompromised babies.
Exactly,
Okay, they do not
exactly.
present with classical presentation of septic hip like infection, pain or deformity like that.
In
The
one
issue
case,
is how to diagnose.
Diagnosis
Yeah.
is not that difficult, but you can find that the child is not moving the hip. You cannot, and if you move it, there will be he or she will cry, but there will be some swelling you can feel, but we cannot drain it because we cannot give anesthesia to this child. No, in one case, I got a case in our Green Life Hospital that was a bilateral septic hip in both the sides, and we put a needle, and I could aspirate both the hip. I could aspirate both the hip by a wide bore needle, and I put this pass for culture and sensitivity. But Rumel has said that he was already getting the higher antibiotics, you know. Then the pass came as no growth, but I could remove the pass. Then the child then improved. The child improved, and I would like to. But I don't know. But I don't know the follow up. You know.
I would like to add in this situation. If you have any suspicion, try to confirm your diagnosis by doing MRI and ultrasonography. That picture will not help you. And if you have any suspicion of any collection in the joint, okay, then aspirate the joint. You have, as you have mentioned, you have aspirated. Aspiration can help a lot. Since your patient will be getting a lot of antibiotic, simple aspiration may be enough to salvage the joint. So I would recommend take this patient very seriously. Okay, go for this investigation. Ultrasonography can be done. It is not very difficult.
Ultrasonography
can be done bedside if the facilities are there, and if you have suspicion, if you are not confident enough, then take the help of senior people so that they can aspirate the hip joint. Okay, that can help the joint. Otherwise, the joint will completely go. There will be chondrolysis of all of the head and neck of this femur, and you will not be able to do anything for these babies.
Yes, thank you, Rizvi. I think in these cases, you have to tell the parents about these unpredictable results and everything, you know. We cannot guarantee because these are already late. When we get the patient from the this NICU, we get very late. Any other questions?
Other issue, the other issue, I do not know whether you have discussed it or not about this antibiotic, the duration of the antibiotics. Okay, give the parental antibiotic for the minimum 3 weeks, and then
oral antibiotic
for 6 to
6 to 8
and 6 to 12 weeks if necessary.
Okay, bye.
Thank you, sir.
Any other question?
Professor Bari sir, do you want to say something?
আমি আর কিছু বলবো না, আমি বিদায় নিচ্ছি। আমি এখন ইজিপ্টে ঢুকবো। আসসালামু আলাইকুম।
কোথায় ঢুকবেন?
ইজিপ্ট।
আমার ইজিপ্ট, কায়রো।
ফ্লাই করতেছেন নাকি আপনি?
না না না, ওখানে আছে আর্থ্রোপ্লাস্টিক আর মস্টিনোমি। আর 3 দিন ধরে প্রোগ্রাম হচ্ছে, তো আমি 10টা
জুমে ঢুকবেন।
জুমে ঢুকবো। আমি পুরো চলে যাচ্ছে। বেস্ট অফ লাক, রাশিয়ান রিপাবলিক।
Yes, best of luck for you.
Thank you very much. খুব ভালো হয়েছে। Thank you very much.
Thank you very
আসসালামু
much.
আলাইকুম।
Assalamu alaikum. Then
অনেক ধন্যবাদ কোয়ারিদা, রেজবি ভাই, আল্লাহ আসসালামু আলাইকুম।
আচ্ছা
Sir,
মেহেদি
last of all,
other
sir. So last of
question.
one question came from Kaisar Rabbi. We can do the, it's the information. We can do the parachute test to find out whether the baby has any hip problem or not.
What?
Parachute test. He just mentioned that we can do the parachute test to find out whether the baby has any hip problem or not.
I'm not sure. The parachute test can give us any idea about this septic hip joint or not. Parachute test is done for other reasons, for neurological reasons. But
Yes, psychological reason.
I'm not sure that this is a good test in case of septic hip joint. Nada can
I don't know. Romel, do you know?
No idea about parachute test, sir.
না আচ্ছা আচ্ছা আমার মনে হয় যে
Sir, I want to ask Dr. Kaisar Rabbi.
Kaisar Rabbi,
Have you seen this yet before or not, or he has any experience about this? Dr. Kaisar Rabbi can meet.
স্যার আসসালামু আলাইকুম স্যার,
হ্যাঁ
থ্যাংক ইউ স্যার। আমরা যদি পেশেন্ট বা বেবিটাকে যদি লিফট করি এক্সিলাতে ধরে, যে হিপটাতে পেইন থাকে ইউজুয়ালি বেবি সেই হিপ কম নাড়ায়, এটাকে আমরা বলি প্যারাসুট পোশ্চার। মানে প্যারাসুটে যখন এ করে, it indicates that baby has some hip pathology, that's why then we can go for MRI or ultrasonogram, because otherwise পেশেন্ট যখন আইসিইউতে থাকতেছে বা এনআইসিইউতে যখন থাকতেছে, বেবি ইজ অলওয়েজ ক্র্যাঙ্কি, অল্প একটু টাচে ব্যথা হচ্ছে, সো উই ক্যান লোকালাইজ যে কোন জয়েন্টটাতে স্পেসিফিক ব্যথা হচ্ছে বা কোন জয়েন্টটাতে বেশি পেইন হচ্ছে বা কোন জয়েন্টটাতে প্রবলেম। এটা জাস্ট নন ইনভেসিভ একটা টেকনিক, উই ক্যান ইউজ দ্যাট আই থিংক।
তুমি কি এটা কোনো লিটারেচার বা কোনো পেয়েছো?
আমরা আমি আমার ফেলোশিপের সময় এটা আমরা টেস্ট করতাম যে এর কোনো পেশেন্টের যদি মানে কোনো বেবির যদি আর্লি যেমন ক্যানুলা বা ইন্টারভেনশনের কোনো হিস্ট্রি থাকতো বা আইসিইউতে অ্যাডমিটেড কোনো বাচ্চা যদি আমরা দেখতাম, তখন আমরা এটা করে দেখতাম যে তার হিপে কোনো প্যাথোলজিস আছে কিনা। হ্যাঁ, হাউ দ্য বেবি ইজ মুভিং বোথ his or her lower limb.
both the lower limb. আচ্ছা ঠিক
Right.
আছে,
good.
this is good addition,
Quite logical.
and quite logical.
Bobby sir, question hip niye bolche sir?
Sir, something.
Rizvi,
Yes.
I am Partho from Silet.
Sir,
Are you late today?
না আমি তো আছি, আমাকে তো
পার্থ আছে, পার্থ, হ্যাঁ পার্থ আছেন, পার্থ, হ্যাঁ আমি কোয়েশ্চেন গুলো শেষ করতে চাচ্ছি, কোয়েশ্চেন শেষ হয়ে গেছে না?
sir, already question is finished.
আচ্ছা ঠিক আছে, পার্থ বলেন।
আমি কথা বলছি।
পার্থ আছে, শঙ্কর আছে দেখতেছি, হ্যাঁ, if you want to add anything, পার্থ বলেন।
আমাদের রিজভি, what রিজভি asked the question about the neonatal problem of septic hip. That is the Thomas Smith arthritis actually.
রিজভি মনে হয় চলে যাইতে চাচ্ছে, জামাটা খুলে ফেলছে।
দাদা আমি sorry, excuse me.
আচ্ছা ঠিক আছে, পার্থর কথাটা শুনে নেন। হ্যাঁ পার্থ বলেন।
Please mute your TV. Any TV is running on, I think. Please mute.
আমাদের Thomas Smith arthritis is the neonatal septic hip actually. It is a very important problem. You must diagnose clinically, absolutely clinically. And actually, what Professor Corey told, actually the general anesthesia is not possible. If you suspect that you have got the arthritis, you must really have a arthroscopic intervention also. One thing I like to say that in nowadays the incidence of the Cangelia kingi is increasing below the age of 2 years. That is a very important thing I like to say. So you must really know about the Cangelia kingi in septic hip infection by doing so many investigations like PCR and procalcitonin. I think I told in the last lecture also, last seminar about it actually. Anyway, it is the high index of clinical suspicion is everything, and the immediate treatment একটা কথা বলা আছে, যদি সাসপেক্ট করেন ইউ ওপেন দ্য জয়েন্ট, যদি কিছু পান না কিছু হবে না, আপনার কোনো ক্ষতি হবে না, না করলে ক্ষতি হতে পারে। বহু আগের কথা, আমাকে আইব্রুক সাহেব কথাটা বলছিল বহু আগে। তো এনিওয়ে আমি দুইটা প্রশ্ন করছি। কথা হলো যে এই যে আমি শুনছি যেটা মোর অ্যাডভান্স সার্জারি রিগার্ডিং দ্য পোস্ট সেপ্টিক কমপ্লিকেশন, এখানে ডিফারেন্ট টাইপ অফ অস্টিওটমি, এলিজারো, ডিফারেন্ট টাইপ অফ complex treatment is going on. What is the result actually you are getting actually overall? And ultimately, we are doing the replacement surgery also. What is actually, before doing the replacement surgery, we are doing different type of osteotomy, different type of this and that. What is the real result? And I like to ask Qazi Shahid, how we have actually classified the criteria of a result, in which course, and what is the period of your follow-up. Whether it is wise to do different types of complex osteotomy before total hip replacement. Which one is better? Have you got any comparative study? Thank you.
So far, all the patients that I have seen in my presentations, they are all under my follow-up, sir. I have a total only 10 patients actually who have the septic hip sequelae. The longest follow-up one is only 4 years right now. So I think I should not comment anything on that because my follow-up series is very small. If anyone from the
আপনি follow-up করেন, কোন স্কোরে follow-up করেন, what is your criteria?
কোনটা স্যার? হ্যারি সিপ স্কোর স্যার। হ্যারি সিপ স্কোর, জি স্যার। এটা দিয়ে follow-up করেন, জি স্যার।
Within this 4 years, your score is how much?
স্যার অলমোস্ট আগে মানে ম্যাক্সিমাম খারাপ যেটা ছিল স্যার অলমোস্ট নিয়ার অ্যাবাউট 55, এটার ম্যাক্সিমাম ইমপ্রুভমেন্ট 74 পর্যন্ত আমি আসতে দেখছি স্যার।
Less than 70 is poor actually.
হ্যাঁ স্যার, 55 যেটা ছিল একদম সবচাইতে খারাপ, সেই 55টা 74 পর্যন্ত আসছে। আর যেটা ইনিশিয়াল রেকর্ড অ্যারাউন্ড 60 to 70 এর মধ্যে ছিল সেটা 85 ক্রস করছে স্যার। কিন্তু শুরুতেই যেটা অনেক বেশি কম সেটা খুব একটা বাড়ে নাই স্যার।
That is my question, because we are doing all the complex surgery, but we don't know about the result. What is actually the result, or what is the follow-up? You must classify it actually. Regarding the total hip replacement after the age of maturity, whether this type of complex surgery is interfering with it or not, that is the one other question actually. That is my
so
thing.
Far in my fellowship at Korea and at India, I have seen that all the surgeons are actually divided into two groups. That those who wanted to do the total hip arthroplasty after this corrective or deformity correction operation procedures. First group, they wanted to remove the disease portion of the head or neck remnant or whatever it is there and put a special like things into that acetabulum, and they correct the deformed femur back into its anatomical position and leave it for union. Once the union has been achieved, then they go for the total hip replacement. So it's a two-stage procedures. And there is another group, like Dr. Rizvi sir said, they wanted to do it in a same sitting. But if I remember correctly, my professor Hyun Kim always told me that if you wanted to do it properly, it should be done in two settings, so that the total hip replacement will be in a perfect position. But again, two schools of thoughts are actually there. Both have their own merits and demerits.
Now, I am saying that you are doing all these sorts of complex osteotomy in actually pelvis and also in the trochanter. Whether it will interfere or any problem regarding total hip replacement procedure actually.
Definitely, it will be a difficult total hip replacement that I would like to send to my senior arthroplasty surgeons, sir.
Acha Rizvi, Partho, I want to add. But why then we are doing these osteotomies before going for total hip? This is because the relief pain and allow the child to walk almost as far as possible normally without pain till its maturity. We cannot do total hip in premature age. At 6-7 years of age, if you do the osteotomy, if you transfer the trochanter, then the child will walk without pain, with some difficulty but without pain. That is the indication for these osteotomies. as far as I know.
করার পরে টোটাল হিপে কি কোনো প্রবলেম হবে কিনা?
না না, ওই যে এই প্রশ্নটা আমি করছিলাম রিজভিকে, এবং এটা ওই যেটা ববি যেটা বললো যে ডেফিনেটলি তো কিছু প্রবলেম হবে, কিন্তু দ্যাট প্রবলেম ক্যান বি ম্যানেজড by doing another corrective osteotomy at that time and 2-stage procedure.
স্যার যেগুলা ভ্যারাস ভালগাস আপনারা করছেন ছোটবেলায়, তার ফলো আপ যেগুলা রোমেলতম ওরা দেখাইছে, আমার কাছে তো অ্যালাইনমেন্ট খুব খারাপ মনে হয় না স্যার। ওরা যখন অ্যাডাল্টে আসবে
তখন আরো অনেকটা কারেকশন হয়ে যায়।
হ্যাঁ, তো আমার মনে হয় না এর কোনো টোটালি
আমরা সেটাই বললাম যে যদি কারেকশন না হয়
সাপোর্ট অস্টিওটমি এইটার বেলা ছাড়া আমার মনে হয় স্যার অন্যগুলো তো হবে।
আমি পেলভিক টাইপ বলছি, কিন্তু পেলভিক
ওইটাতে স্যার একটু
পেলভিকটাতে একটু ডিফিকাল্টিজ আছে, কিন্তু
করা যাবে না স্যার,
কিন্তু সেটাকে পেলভিক সাপোর্ট অস্টিওটমিতে করা যাবে
এটা সেলভেজ।
আর পেলভিক সাপোর্ট অস্টিওটমি তো পেলভিক সাপোর্ট অস্টিওটমির যে ইন্ডিকেশন সেইটা টোটাল হিপ পর্যন্ত ম্যাচুরিটি পর্যন্ত তো আমরা ওয়েট করতে পারি না, এর আগে তো বাচ্চাকে হাঁটতে দিতে হবে, সেটাই হলো সমস্যা। থ্যাংক ইউ। হ্যাঁ থ্যাংক ইউ। আমার মনে হয় যে আর 10টা বাজে।
10%। Yes sir, 10%.
10%। আমার মনে হয় যে আজকে আচ্ছা শঙ্কর কিছু কথা বলবো নাকি, বা জুনিয়ররা দেখলাম অনেকক্ষণ আছে।
Dr. Shamal Devnath was there, is there, Dr. Shamal Devnath? Dr. Shamal Devnath is there.
হ্যাঁ বলা।
Your experience.
আচ্ছা একটা জিনিস আমি বলিনি যে আমাদের শহীদুল আলম ববি, কাজী শহীদুল আলম, আমরা কাজী শহীদুল আলম বললে কিন্তু অনেকে শহীদ ভাইকে মনে করে, যাই হোক কাজী শহীদ বললেই বেশি পরিচিত, এই জন্য ববি বললে পরিচিত। তো ববি এই সাবজেক্টটা দেওয়ার কারণ হলো ববি কিন্তু কোরিয়াতে 1 বছর ফেলোশিপ করে আসছে উইথ এ ভেরি গুড সার্জন, and he about this he knows, he has got lots of experience in Korea, that's why we can learn many things from him. So ঠিক আছে সাইমল বলেন কিছু, আমরা শেষ করতে চাই।
আমি মানে ববিকে থ্যাঙ্কস দেওয়ার মতো ভাষা নাই, হি ডিড এ ভেরি নাইস এক্সিলেন্ট জব। আমি একটা কোয়েরি ছিল ছোট্ট, যে লাস্ট প্রেজেন্টেশন যেটা ছিল, দ্যাট পেশেন্ট হ্যাড এ ডিসলোকেশন অ্যাজ ওয়েল অ্যাজ ডিফর্মিটি অফ দ্য অ্যাসিটাবুলাম, দ্যাট ইজ এ retroversion of the acetabulum and big deformities. Can you explain why did the deformity has happened to the acetabulum as the head was dislocated far away from the acetabulum after working boy? That was a near adolescent boy.
In that pelvic support osteotomy that we have done in my last cases, sir.
Last case. Why did the deformity of the acetabulum happen on that case?
Because he presented to us when he was 14 years of age, but he has been diagnosed with septic hip when he was 8 years of age. So actually he presented to us 6 years afterwards. So I can only assume that he actually, his head and neck were destroyed and got out of the acetabulum. So that acetabulum for a long period of time did not have any stimulation to growth, which is actually the intact head of the femur. So because as there is no stimulation, so that acetabulum didn't go as it was supposed to be. It didn't cover, its acetabular index had got raised up and it is almost get straight up. So that is my explanation, sir. Over the period of 6 years when the head was destroyed, it got out of the acetabulum. So the basic thing is the head of the acetabulum and the head of the femur, they actually need each other to maintain their growth as a stimulus. So
acetabulum growth
will definitely
আমরা কিন্তু DDH এও দেখি যে নেগলেক্টেড কেসের DDH এ একদম acetabulum সোজা স্ট্রেট হয়ে যায়, তো এটা হেড না থাকলে তো হবে আর কি, আমারও মনে হয় তাই।
আমি আরেকটু জানতে চাই যে those who are advocates of total hip replacement in case of long standing dislocation, what is their approach to reduce the bring back the head to the level of the acetabulum? How do they do that?
এটা এখন রিভিউ চলে গেছে মনে হয়, আমরা ওটা
I have presented in my presentation that sir, that before this difficult cases where the proximal migration is there, that iliofemoral destruction actually helps a lot.
Iliofemoral destruction
we bring that upwardly displaced femoral portion back to its normal anatomical position, at least at the level of the acetabulum, then we go for the.
এটা বইতেও আছে যে আইলিওফিউমেরাল ডিস্ট্রাকশন করতে হবে, নিচে নামলে তারপরে
two stage surgery sir.
Thank you Bobby, well done. Thank you once again.
Thank you everybody. Already we have expressed our already mentioned time. Now I would like to invite Dr. Saror Ibn Salam to announce the next program, that is next webinar, and overall we have enclosed our very important chapters. Just Dr. Saror Ibn Salam, can you mention, and after that we shall conclude our today's session.
Thank you, Mehdi, very much. Thank you for presenting in a nice way, and for congratulations, Bobby, for a great presentation. Our next program is on cerebral palsy, and I'll be the speaker. Next. And next week will be Professor Quazi sir with SCIFI.
Sleep capital femoral
epiphysis.
Yeah.
And I will let you know the others later on. So, sir, would you
yes, Professor R.R. Quazi sir, just you conclude it today's.
So thank you Bobby for your nice presentation, and thanks all the seniors and the participants. I think we are now we have we cannot finish discussion in every subject, you know, but as far as we can discuss among ourselves. I was telling on the last seminar webinar also, last meeting, that even we can discuss among ourselves. We can send any questions to our email. For any case, I like to reply, you know, even on our Facebook page, POSB, you can put your case, you can discuss there also. This is open to all, not for the members only. So thank you very much. Thank you all once again. Thank you very much.
Thank you everybody. আমি একটা কথা, আমরা যেহেতু নিজেরা আছি একটু বাংলায় বলি, কারণ অনেক বিদেশি আছেন, শুনছেন, নেপাল থেকে শুনছেন, ইন্ডিয়া থেকে শুনছেন। সেটা হচ্ছে, আমরা যখন আসলে এই ওয়েবিনার গুলোতে আসি, ডেফিনেটলি আমরা আমাদের সবাই তো দেখতে পাই আমাদের, তো আমরা অনেক সময় আমি দেখছি যে আসলে টিভির এর ভিতরে অনেকে আমরা ভাত খাচ্ছি, সেই চিত্রটাও আসছে, অনেকে শুয়ে শুয়ে আমরা দেখি। তো আসলে এই জিনিসগুলা একটু মানে জাস্ট আমি করবো সবাইকে যে আমরা সবাই বসে আমরা যেভাবে কাজ করছি, ঠিক এটা প্রেজেন্টেশনটা আমরা সবাই কিন্তু ইনভলভ এটার সাথে, অর্থাৎ এটা কিন্তু ইন্টারন্যাশনালি সবাই দেখতে পাচ্ছে। তো আমি যদি ওই সময় আমার পার্সোনাল কোনো কাজে ব্যস্ত থাকি, আমি আমার ভিডিওটাকে মিউট করি।
তখন ঠিক আছে, আমি মেহেদি, আমি আগেও একদিন বলছি যে তখন তোমার ভিডিওটা তুমি অফ করে করো। হ্যাঁ, তুমি একটা পানি খাইতে চাচ্ছ, ভিডিওটা অফ করে করো, এটা তো নর্মস আর কি। তাইলে তো তোমার নামটা আছে, দেখা গেল না। এটা আমাদের মানা উচিত। কেউ টেলিভিশন চালায়, কারো বাচ্চা চিল্লাচিল্লি করে,
শুয়ে শুয়ে না করি, আমরা একটু বসে শুলে দেখা যায়, বোঝা যায়, সেটা একটু আমার মনে হয় আরো ভালোর দিকে একটু যাবে। আমরা যেহেতু শুরু করেছি, অবশ্যই আমরা একটা ভালো জায়গায় পৌঁছাবো ইনশাআল্লাহ।
থ্যাংক ইউ অল।
আসসালামু আলাইকুম। মেহেদি ভাই, শুধু শুয়ে না, অনেকেই দেখলাম একদিন খালি গায়ে।
না না না, মানুষের
আজকে দেখলাম একজন খালি গায়ে ভাত খাচ্ছেন, সব বিষয়টা এরকমই। ঠিক আছে,
বলা হয়ে গেছে, শেষ
বলা হয়েছে।
আচ্ছা, থ্যাংক ইউ ভেরি মাচ। আমরা এটা কালেকশন হয়ে যাবে।
থ্যাংক ইউ মডারেটর স্যার, থ্যাংক ইউ মডারেটর স্যার, প্রেসিডেন্ট পজি,
থ্যাংক ইউ এভরিবডি,
থ্যাংক ইউ ববি, ধন্যবাদ। আসসালামু আলাইকুম। Brilliant, nice presentation.
Very good presentation.
হ্যাঁ, না থ্যাংক ইউ, খুব ভালো লাগছে। ভালো প্রেজেন্টেশন এরকমই হওয়া উচিত। তথ্যবহুল শুধু না, সবকিছুই বলতে হবে, খালি তথ্যবহুল কেন।
থ্যাংক ইউ ববি, ববি থ্যাংক ইউ।
তবে মেহেদি, ববির আরেকটা পরিচয় দেওয়া হয় না, ও যে আপুয়ার ট্রমার যে ইয়ে হইছে,
হ্যাঁ,
যে এটা কিন্তু আমি ভাবছিলাম বলবা, আমি তো মিউট করা, জায়গা সবাই জানে নিশ্চয়ই।
তাও আপনি বলেন আরেকবার, অসুবিধা নেই।
না না, ঠিক আছে,
আমরা বলেন বলেন।
আরে ঠিক আছে, আপুয়ার কান্ট্রি রিপ্রেজেন্টেটিভ আমাদের বাংলাদেশের।
আপুয়ার কান্ট্রি, আমি থ্যাংক ইউ।
থ্যাংক ইউ, আল্লাহ হাফেজ।
আল্লাহ হাফেজ।